My name is Heather, and I'm with Ask. I'm a family support specialist, and I was just saying that we're happy to have you here today, and I'm excited about the information they're going to share. Today's presenters are Bharat, Chandra, and Moonlay Tung. And just to tell you a little bit about them, Bharat is assistant professor and director of the Undiagnosed Diseases program at the U of I. He's a neurogeneticist and rare diseases researcher. Dr. Chandra will share his experience from the Iowa Undiagnosed Diseases program, and he'll highlight the clinical landscape, challenges, and emerging approaches for individuals with undiagnosed rare diseases. Dr. Moonlay Tung is an assistant professor in the Stead Family Department of Pediatrics at the U of I. She's an adult hematologist and clinical geneticist with a research interest in rare hematological disorders. Dr. Tung will share her experience working with patients with rare genetic disorders and the challenges that these patients faced after being diagnosed with a rare disease. All right, and there will be a question and answer time at the end of the session that they will go ahead and direct. But for those of you who may be looking at the schedule, you'll notice also from 1 to 3 today. This is in the keynote room upstairs. They're hosting a special conference within a conference, so that's a great time that if families or individuals want to come and ask them specific questions, kind of like a roundtable discussion like last year, that would be an additional time for asking questions. So I'll turn it over to you.
Thanks, Heather. Thanks, Heather. It's always an honor and pleasure to be speaking here. It kind of feels awkward to speak in a microphone in a room where I can be loud enough to talk to you all. So I don't have any financial disclosure pertinent to this talk, and I don't have a structured outline. What I want to do is to just share the stories of the patient who I've been seeing in my undiagnosed disease program. Most importantly, it all revolves around one word, which is diagnosis. And diagnosis, as we know, is derived from the Greek word, which means knowledge. And knowledge can be empowering to both physicians, researchers, as well as patients, most importantly. So majority of my patients will state some of the common theme that their physicians have told this is the best they could do in 2025. Unfortunately, there's nothing much they have to offer. Come back in 2 years or don't come back. We can't do much. And, or they'll say that let's use time as a tool, but we know that that doesn't always pan out in favor of the patient, because if we just want the disease to progress so that we could figure out what the patient has, eventually the disease will take a toll on that patient's life. Next slide, please. So to understand what a physician thinks, we have to go back to the cognitive philosophy behind making a diagnosis. And essentially, when someone goes to med school, undergoes training, they are learning what we call pattern recognition. And these are the two fundamental principles that actually drives a clinician's cognitive process. One is Occam's razor on the left, which states that simplest answer is the best answer, depending on the facts that you're analyzing. And on the right is Thomas Bayes, who was an English monk who actually gave us Bayes theory, which is more objective way of analyzing facts, evidence. And as evidence changes, it states that the probability of having of a fact also should change. And essentially, an early career doctor will start with Bayes, and eventually as they get more experience, as they start seeing more patients, they tend to identify pattern. And when they're following Occam's razor on the left, they tend to dismiss what are the outliers. If something doesn't fit, they tend to ignore because they want to box in, they want to come up with a diagnosis. Diagnosis is so profoundly important for clinicians that they can't accept the fact that there's no diagnosis for their patient. I'm pretty sure you guys must have heard these buzzwords, precision medicine. There's a lot going around. I mean, since 2008, when President Obama initiated the Precision Medicine Initiative, it was all revolving around like every individual will get an accurate or precise diagnosis. But oftentimes people misunderstand or they use these terms as synonyms, but they are not. So precision medicine, as you can, precision means that dissecting things evidence apart. So if you look at the all the way for the right, that circular donut, those red dots, as you can see, they're all pretty accurate to the center blue dot, which is actually the diagnosis. And those dashed lines that you're seeing there, that is the confidence interval. How confidently you can tell that someone has that disorder or diagnosis. So although you're precise, you're making different measurements, you're doing different tests, or you're making different diagnoses, but you are not accurate. Whereas the green dot in the center is accurate enough. As you can see, it's fairly confident and it's fairly close to the diagnosis. There's no way we can find an accurate diagnosis ever, because we know that the complexity of human body is similar to the complexity of the universe. We'll never be able to find what exactly is the truth, but what we can get to is closest to the truth. So how do we define undiagnosed diseases? This is pretty intuitive, and it is, I think, in patients' words, they are suffering from some kind of unknown or complex disorder which no one can figure out. And as NIH Undiagnosed Disease Network puts it, it's defined as long-standing symptoms or elusive medical disorders that has not been solved despite multiple subspecialist evaluations. To understand undiagnosed diseases, we need to understand what is a rare disease, because up to 90% of undiagnosed diseases are in fact rare diseases. And it'll be surprising to you all that rare disease is pretty common. I mean, 1 in 10 American has a rare disease. Over half a billion people in the world actually suffer from a rare disease. And if we put that into perspective, there are about 30 million people in the US alone who have at least one unique kind of rare disease. And this is similar to diabetes or cancer. So if you talk about the prevalence of diabetes in the US, about 27 to 33 million people are affected with diabetes. But if we look at the funding and the infrastructure and other support mechanism that is available to patients with diabetes compared to rare disease probably gets nothing. Unfortunately, 50% of these patients are children, and 75% of those children actually would have a neurological manifestation as the primary presenting symptom for their undiagnosed rare disease. And because of this everlasting diagnostic odyssey, there's not much in terms of natural history studies for these disorders. Eventually, the disease will either take a toll on that patient's life, or by the time people figure out the red flags and are able to establish a diagnosis, it's already too late. And hence, there's no structured way to monitor the disease progression, and also to develop therapeutics where you could actually figure out what are the outcome measures that you're going to measure for gene therapy or any kind of novel drugs that we need to develop. And that could explain why 95% of these disorders don't have any FDA-approved treatment. So if you want to broadly classify these undiagnosed diseases, they fall into these 4 clusters. The top left is known common disease, which may sometimes manifest with atypical presentation. For example, individuals with diabetes, they may present with diabetic amyotrophy, which can get undiagnosed because it's a very rare complication of diabetes. The second category on the right in green is known rare disease which manifests with typical presentation, but unfortunately, we don't have that many rare diseases experts, so these patients remain undiagnosed for several years because they are getting bounced around from one primary care provider to another, one specialist to another, one neurologist to a different neurologist or a cardiologist to see their cardiac symptoms, but no one is able to actually put all these different pieces of the puzzle together to figure out, oh, there's a unifying genetic disorder that could explain all those different system-wide manifestations. The one on the bottom left is known rare disease with atypical presentation. So these are the challenging rare diseases which can even be perplexing to a seasoned rare disease expert because, as we know, some of these genetic disorders are affecting several body systems, and sometimes they may not present with a typical manifestation, and it can take several years to figure out. The one in black is essentially a black box, and that's why I use the color black as unknown rare disease. This forms the majority of undiagnosed diseases. About 50% of undiagnosed diseases are unknown rare disease. These are the conditions that no one knows. They don't exist in literature. You can Google, you'll find nothing. And OMIM, which is the largest database of rare diseases, doesn't have any information about them. And that is because in our body, we have 22,000 genes. We only know the function of 4,000 genes. So we still don't know what those remainder of 18,000 genes do in the context of human disease. And it's not always so simple to establish a rare disease diagnosis. And although I showed that those were 4 distinct entities, but if we look at a rare disease manifestation, especially the undiagnosed diseases, sometimes they may present as common diseases. For instance, if someone has a mitochondrial disease, they may present with diabetes while they're young, and their primary care physician is fairly confident in managing diabetes, and they'll continue to treat diabetes. Along the way, they'll start to complain migraines. Again, the primary care provider will be more than happy to treat migraine or refer them to a neurologist who will just focus on the migraines and nothing else. Subsequently, they develop a stroke. Then they get referred to another subspecialist, which is a stroke neurologist, and the stroke neurologist will probably just treat the stroke with aspirin. And this cycle goes on and on until someone is able to connect these dots and think that why this 30-year-old person has diabetes, stroke, and has short stature and has deafness, and then they will try to figure out, okay, could this be mitochondrial? So rare disease is rare, the reason behind why rare disease is so rare is because no one ever looked or thought about those possibilities. Next slide. So this is an example of one of my patients who actually had a rare disease, and this was all over her charts, and those colored dots, those bubbles represent how many times different physicians have used that term. And as you can see, the top diagnosis here is functional movement disorder. So you can tell that this patient is undiagnosed, but if you asked their PCP or any medical provider, they'll say they have a diagnosis. So all these are diagnoses in terms of clinicians. So could you click? But this patient had Niemann-Pick C disease, which is a rare disorder, and that could explain all the clinical picture for that person. But by the time the diagnosis was made, it was already too late. It took 20 years for us to establish a diagnosis. So this chart over here, I'm not going to go into details of this, but just want to allude to this, that if from the time the symptoms start to diagnosis, it takes about 5 to 25 years. And these blocks, they're showing the patient's journey. They go back and forth from one specialist to another. Majority of the time, the system that is affected is either the brain or the nervous system, or the musculoskeletal symptom, and sometimes they are given a vague diagnosis of fibromyalgia or chronic fatigue syndrome, etc. If it manifests early, it can result in several psychosocial issues like difficulties in school and getting proper support and accommodation in school. A lot of times they will be seeing different various neurologists because the main symptom, as we talk about, is neurological symptom. And as we discussed about the Niemann-Pick C case, sometimes when the neurologist actually are unable to make a diagnosis, they will call it functional movement disorder or functional disorder or mental health related to mental health. It's always the chicken or the egg. Whether is it the Diagnostic Odyssey that created this psychological stress in the patient that resulted in depression, anxiety, or was it a depression, anxiety that caused those symptoms? Then in advanced or terminal stages, those red flags will start to emerge, like abnormal movement disorders, dystonia, frequent falls. And that is when someone will realize, oh, this could be a late complication of this rare disease. But by the time the diagnosis has been made, it's already too late because you can't do any of the interventions, including physiotherapy or rehab. Next slide. So this is the same patient with Niemann-Pick C, and I just wanted to show how, as her symptoms were progressing, what was going on in her life. So in her 20s, she always wanted to help patients. This patient wanted to become a nurse. She got into nursing school, and then she, because of her pain and others, she took up this certified nursing assistant diploma. Then she started to have these gait abnormalities a year later. And 5 years down the road, she developed severe ataxia, seen several neurologists. She was treated for Parkinson's. She was given different assortment of medication, and none of them actually worked. In 25, and she also lost her job along the way. And then she underwent a surgery. There was no improvement with the carpal tunnel surgery. Then eventually, about 20 years, 15 to 20 years later, she was found, she presented to our clinic. We also had no clue what was going on with her. And finally, with the genetic testing and family history, we were able to establish a diagnosis. Next slide, please. But what I wanted to emphasize is, if you just click. This is not that patient. This is a similar patient that has clinical features identical to the patient that I talked about. And none of the clinicians actually looked into this publication, which existed in the literature. Or even when they searched the literature, this paper popped up. This is one of those, like, when you do a PubMed search, you'll probably come across like 5,000 articles related to ataxia. So this is paper number 4,999. So there's no way a doctor will be able to go through 5,000 papers for one patient or one patient's symptom. And that is one of the biggest challenge. We started with diagnosis, which is knowledge. And at the same time, although doctors go through extensive training in med school, but it is all about constant learning and finding out how additional knowledge could actually help them solve a diagnostic mystery. And that is why it is an iterative process. The patients do not expect their doctors to be experts, to know everything. But as long as you can make a promise that, okay, you will try to keep looking, keep searching into the literature, show them what actually is the problem, that the literature is so vast that you'll need some time to actually look over every single papers to help them solve their diagnostic mystery. They'll be okay with that. They understand that we are busy, we are seeing close to 60 patients a month, and every single patient is unique and challenging. But it's the effort that counts, as one of my patients' mom told me. So just to summarize the challenges of Diagnostic Odyssey, there are direct challenges such as unnecessary tests and procedures such as the carpal tunnel surgery, delay in receiving appropriate care, because for some disorders like neurometabolic disorders, if you start the right kind of nutritional therapy, you may actually help the patient by delaying disease progression. Also, sometimes patients just lose trust in healthcare and they just stop seeing doctors. Indirect is the uncertainty. We have to understand it's not just the patient, it's the family. It's the entire family structure that gets affected by an undiagnosed disease. It can affect both the family members' mental, emotional, and mental well-being. And because of lack of support, since they don't have a diagnosis, there's a lot of support that exists only for individuals with an established diagnosis. So these patients may not be able to receive those benefits, and then they are suffering in a social isolation. Given that there's no support mechanism, family members actually have to quit their full-time job to take care of them, and that actually results in economic loss. And that's why there was a cost-effective a health economics paper on undiagnosed disease, and that actually found that for every single undiagnosed disease patient, the economic cost is about $5 million. And also, physicians who are not aware of undiagnosed disease, or they do not entertain the possibility of an underlying disease that does not exist in literature, it may lead to very difficult interactions, or physicians may tend to avoid those challenging cases because no one likes defeat, no one likes failure. So majority of those physicians want to walk home with a victory, with that they were able to make an impact by finding an answer. No one wants to walk home with a failure that, oh, I saw 5 patients today and I had answer for none of them. Next question here is the why accurate diagnosis matters. I mean, we did talk about those cost, health economics, and other benefits, but why does it matter? So besides the natural history study, there are certain treatment that is highly specific to disease, and sometimes it can dramatically change the disease outcome. So I just wanted to talk about this story where this 23-year-old female was seen at our neurology clinic for epilepsy. She had generalized epilepsy since she was 2, and at 16, she developed hypertension, anxiety, ADHD, depression, as well as severe acne. And at 23, she presented to our clinic with refractory epilepsy, which means that her seizures were not responding to standard medication. So we did brain MRI, and as you can see, the arrows are showing the structural abnormality over here in white. These look like brain tumor, but it's a very specific kind of brain tumor. We call them SEGA, or subependymal glial astrocytomas. And if someone has that, then you can, if you identify the pattern, you start looking for additional clues. So this is not this patient's picture, but the acnes were like this that you are seeing on the face, and she also had a skin lesion. So this entity is defined as a syndrome, tuberous sclerosis complex, which is caused by mutation in TSC1 gene. And the good news here is this is treatable condition. We have specific treatment available for this. Then as a cascade testing, we did MRI of her body, and we found that she had tumors elsewhere, which went unnoticed for several years because people were just treating her symptoms, which was hypertension, rather than doing those scans to look for additional cause. So here, how the outcome changed. Before accurate diagnosis, she was on a combination of anti-epileptic drugs, and she was planned for vagus nerve stimulation, which was an invasive surgery. After we established the diagnosis, she underwent a focal resection of that brain tumor, then underwent mTOR inhibitor therapy, which is very specific, and her seizure frequency dramatically came down, and she became seizure-free like 3 months after starting the treatment. Next slide, please. So if you could just press again. So now we are going to talk about the black box, or the tier 4 category, which is unknown rare diseases, where we don't know what exactly is going on. It doesn't exist in the literature. So I want to share Sutton's story. I'm not sure whether Sutton's mom was supposed to come, but I think there's something going on in family. So yes, nevertheless. So Sutton was a healthy baby and was feeding okay. That's his cute picture at 2 months of age. That's with, on the left is with mom, on the right with dad. Next slide. Then at around 3 months of age, he started to get viral infection, and after a viral infection, he developed lethargy. And her mom actually had to really fight for admission at the ER because no one was taking her seriously. So at 3.5 months of age, he was treated for pneumonia, and he started to progress. By 4 months of age, he started developing epilepsy, epileptic spasms. His EEG was normal, but he had raised lactate, which is indicative of possible mitochondrial dysfunction or metabolic disorder. he continued to get worse. By 5 months of age, he developed feeding issues and he required G-tube placement. And at around 5.5 months of age, he became so sick that he needed to be hospitalized again. And that's him where he was. He needed intubation and he was also requiring continuous EEG monitoring. So he had an undiagnosed disease because he had already completed most comprehensive evaluation, which included MRI, brain, and genetic testing, which was negative. And Sutton's mom was told that that was the best his doctors could offer in 2015. So the Undiagnosed Disease Network was established to solve these kind of challenging cases by the NIH. And as you can see, Iowa doesn't have an undiagnosed disease center. And along that line, we decided to set up something for undiagnosed patients living in Iowa because it was too difficult for them to travel to any of these external sites. And that actually led for us to start the Iowa Undiagnosed Disease Program. This is the vision and mission. I'm not going to read it. And essentially what we do in this program is we talk. We spend about 90 minutes per patient, and we sit down and go over every single details of the clinical history. And we spend close to 6 hours before and after the clinic visit to actually summarize their clinical charts. We also ask them to fax over medical history from other providers that is not easily accessible. Besides that, we do additional imaging if needed to understand what exactly is happening in terms of the disease phenotype. Besides that, we get the raw data for all their genetic testing so that we could analyze it ourselves. And also we do additional research-based genome sequencing and other multi-omics-based testing. So essentially what we are doing is we are integrating research into clinical care, and we are involving the patient in that process. So the traditional approach was the patient, the research and clinical care was separated. Like patients will participate in a research study, but they would not know what exactly is going on. Here, as we find something or whatever progress we are making, we are actively sharing that data with the patient. I mean, it also helps me. I mean, I gave the Excel sheet to my patient's mom and taught her how to actually look through every single genetic variance, and then she's doing it with due diligence. So like there are over 300 genes that we have prioritized, and she's helping me actually, and she's doing a better job than I do. So far, we have enrolled about 70 patients, and majority of these patients, as you can see, have a predominant neurological disorder, such as neurodevelopmental disorder, primary mitochondrial disorder, ataxia, and epilepsy. And given that it's a research-heavy program, we needed additional collaborators who were in there to actually help support this program. And no one gains from it. I mean, most important thing is altruism, and that is the driving force of this program. None of these people actually care about their personal glory or whether they're going to get awards or additional grants or money or papers. They are just doing it because they believe this is the right thing. So some of them actually spend a few hours of their weekend to actually go over some of the details. There are some people who told me that they don't want to waste their weekend on this. I think it's fine. If you think that you're wasting your weekend working on something or helping people is not the right thing, it's your choice. I'm not going to force people to actually commit. But still, I was able to get really good support from all these people. As you can see, Dr. Tung is there, and we have clinicians, Dr. Calhoun, Dr. Nudge, Dr. Safina, Anna Paulson, who's our genetic counselor. She is 100% committed to this program, and she puts in a lot of time and effort. Jim Walker at Harvard, he does disease modeling using fruit fly models. Maddie, who's sitting at the back there, she actually does most of the functional assay for the undiagnosed disease program. And we do have bioinformatics support from Seth, who's currently in Chicago, Dr. Nudge, Michael Chimenti, and Hagar, who's one of my external collaborators. So for Sutton, when we enrolled him in the undiagnosed disease program, this is what we do. We looked at the charts, and on the left, as you can see, these are the objective clinical findings he had. On the right is the metabolic labs that he had undergone. And we looked at the brain imaging, and the peaks that you're seeing, those are what we call spectroscopy peak. And this tall peak that you see is actually the lactate peak, which is confirming the diagnosis of an underlying mitochondrial disorder. So we gave Sutton's mom a partial diagnosis that, okay, from knowing nothing about what was wrong with her kid to a diagnosis that it is likely a primary mitochondrial disease. At the same time, we told her that there are 1,400 genes that are associated with mitochondrial disorders, and we only know the function of 400 genes, so there's still a possibility that Sutton could have mutation in any of those 1,000 unknown mitochondrial genes. And these are the additional tests we did for Sutton through the research-based program. And these are some of the cell-based assays. So Madeline did this mitochondrial copy number, and it looks like Sutton has very little functional mitochondria compared to the control samples on the right. So Sutton's sample in the blue is on the left, and the one in the purple, orange, and green are the control lines. And on the right, you can see this is what we call mitotracker assay, and essentially it's looking at any mitochondrial membrane, which actually will light up once we stain with this dye. So although you can see that Sutton's cells have a lot of mitochondrial fragments compared to the control on the right, but they are non-functional. So to conclude, and most of my patients agree that accurate diagnosis is the most important milestone for any patient's journey. And majority of the time, as we can see, it's due to the lack of awareness, and also it's the lack of advocacy for those patients. Either the patients are too shy to advocate for themselves, or they just believe whatever their doctors or primary care providers are saying. If they say that this is the best they could offer in 2025 and come back in 3 years, they think that that's the truth. That might be the truth for most of the cases, but research, as we all know, it's not clinically validated. Some people are too worried about participating in research, which is totally understandable. But at the same time, research is very important because at this stage, we know so much about genetic disorder and rare disease thanks to the research that has been done in the past 1 to 2 decades. And we also know that UDP model of personalized medicine will eventually become a reality. I mean, right now, given the tests are expensive, majority of these tests are done on a research basis. It might not be commercially viable or feasible, but eventually, as the cost of sequencing technologies and research-based assays drop, it may become the best approach for patients, because if you're spending $20,000 per patient to find an accurate diagnosis rather than wasting millions of dollars in unnecessary intervention, I mean, we can do the math and we know what exactly works. And finally, to wrap up, this is a very nice summary that talks about a good diagnosis, and we know that good diagnosis needs to be accurate, and it should be timely made, because there's no point making a diagnosis like 20 years later when there's nothing much you can do. Patients need to be informed about the diagnosis. They need to be counseled, supported. It should be highly collaborative with other researchers and other advocacy organizations. There's a need for a patient support group for every single rare disease to push for rapid therapeutics development for their disorder. These individuals need to be respected. Even if they don't have a diagnosis, they deserve to be treated with respect. They should not be labeled as someone with functional disorder or psychological disorder. If the doctors don't have a diagnosis, they should not shy away from calling that "I don't know." I mean, there's no harm in stating the fact. Patients will actually respect you for that I don't know what is going on, but I'm going to help you connect you with the experts. Next slide. Lastly, I just wanted to dedicate this talk to two of my UDP patients who I unfortunately lost since I started this program. Meg on the right, top right, and Sutton unfortunately passed away last month. And this is just to acknowledge all these people who have helped me establish this program. Without their help, it would not have been possible. And I like this quote, disease may be rare, hope should never be. All right. I'll turn it over to Dr. Tung.
Right, thank you. I guess we'll just leave the Q&A to the end, and if there are more burning questions, we do have that afternoon breakout session between 1 to 3. So that's more of an informal, smaller groups, we can chat more. So I know Dr. Chandra talked about the Diagnostic Odyssey. I think within our rare disease patients, some of them do get diagnosis, but then we run into this problem about the therapeutic odyssey, which is the next part of what I think as a follow-up I want to talk about. And in some ways, it's a continuation of what I tried to talk about last year, if some of you guys were here. Next slide. Okay. So this is kind of just an overview. I'm just going to briefly talk about the different classification of rare diseases, what the therapeutic odyssey is, but I really want to highlight two examples here where patients' parents have been a strong advocate for even therapeutic development and what that looks like. And then what I feel can be a starting point for parents who have children or affected family members with rare disease. Right. So I'm not going to go through what Dr. Chandra had mentioned about rare disease, but really there are rare disease, there are also ultra rare disease and hyper rare disease. So we see all of these patients in our clinic. And if you come to our clinic, what we conceive as rare, ultra rare, or hyper rare, they are actually not uncommon in our clinics. And some of them not just have one rare disease, they can have two concurrent rare disease. We've seen that before, and that's kind of challenging the paradigm that we've always thought that, well, if you have one disease, it's like one rare disease that's like hitting the jackpot. What are the odds that one individual will do that twice in their lifetime, okay? So about 250 new diseases are classified as rare disease every year, and as Dr. Chandra had shown you, there are millions of people, even globally, living with rare disease. Now, the sad part is the next line is there's only about 5 to 10% of these diseases that have approved therapy. So that shows us how big the problem is and how are we even going to try and tackle this through our profession, through our advocacy. So this is just a paper that shows you what are the emerging themes and sub-themes that have arose from research done in rare disease. As you can see, there are a lot of experiences and emotions that some of us may be familiar with, but there's also a lot of challenges within the healthcare system, as well as the governmental and social services as well. Now, we are part of, I guess, where the challenges in the healthcare system is the Diagnostic Odyssey. That's kind of where we are now positioned to try and help patients in that space. But as you can see, there are a lot more other things that we need to do, whether that's education of physicians, primary care physicians, other subspecialties regarding rare diseases. And that's kind of our contribution into how we can even start to tackle some of these challenges. So I presented this sometime last year, where the other themes that really came up is parents seek therapies and services beyond the clinic. That's why the diagnosis is important. They also require the diagnosis to obtain school services as well as optimized placements. And they leverage the genetic diagnosis in their quest for therapies and services throughout the affected patient's lifetime. Now, when we think about obtaining a diagnosis, yes, it is important, but it only represents the initial phase of an ongoing therapeutic odyssey. And I will show you some illustrative quotes later on, which really emerges from patients that we see in our clinic, and this is through one of the papers that was published in Australia recently that highlights the fact. There are things like the International Rare Disease Research Consortium that is trying to advocate that everyone should have access to a proper diagnosis. And one of their goals is really to facilitate the approval of 1,000 new therapies for rare diseases. That's a huge challenge by 2027. We are halfway through 2025, so we're not quite there yet. For them to achieve this goal, everyone needs to work together. It is not something that one person, one organization will be able to do in the short span of time. And other themes that arose is really this unmet need and urgency to come up with advanced therapies for rare neurological disorders, but there's also that information need, access and equity to therapies and clinical trials, the need of a multidisciplinary team to care for these patients, and an integrated approach to care. And sometimes that involves making very difficult decisions. Yeah. So this paper from Australia actually polled two groups of people. And this is to highlight that clinicians and scientists who work in rare diseases also have the same challenges and the same emotions as well. Like Dr. Chandra tried to say, it's like we try to solve the cases, and sometimes when we lose that battle for our patients, that creates a lot of emotions for us as well. So this paper tried to really look at the impacts and the needs from a clinician and a scientist perspective versus that of caregivers. And this was really trying to understand what people understood about gene therapy, stem cell therapy, other more novel methods of treating patients with rare neurological disorders. Okay. So one of the illustrative quotes is this, and this is not uncommon in our clinic. Every time we discuss a rare condition, and I had a patient come in and said, well, we enrolled in this autism study, say 4 years ago. We gave them data, we gave them some bio specimens, we didn't hear back from them. 4 years later, they get a result in the mail that tells them, we found the genetic answer for your child, this is diagnosis that your child has, and that's all they got. So then they come to our clinic and say, well, what next, right? Can we fix it? What's the treatment? So getting a diagnosis in and of itself sometimes isn't enough, because parents still have to manage all the different symptoms that happens within that diagnosis. And then when we think about therapy, a lot of clinicians are very hesitant to even recommend new novel therapy because they're worried about risk. But this is what caregivers say. If you're living with a death sentence and you have no treatment, and the progression of disease is described as falling off a cliff, which you saw the picture that was shown earlier on, we know that every week, every day counts. For someone like Sutton that Dr. Chandra just presented, it's literally days to weeks. You don't have months to years, right? These patients don't have the benefit of time. If you see your child suffering every day, all you want is something that can help, something that can temper the symptoms, right? And then this is also very common for us as well, because our patients drive 4 hours to come see us, right? It's 4 hours one way, 4 hours another way, that's a long commute. This paper published from Australia says, well, in Sydney you have people who live 5 hours outside of the city. They can't enroll in research, they can't travel. They are the ones who would benefit, but the system is not set up for them to be part of the research study. So an example of this is I had a patient with 2 rare diseases, and his adoptive mom was like, hey, we talked about that clinical trial out at the NIH. Well, given what's happening right now is not a good time to go. They're not taking patients anymore, the funding for that is affected. So we then reach out on their behalf and said, the answer I got from NIH is, well, This is the email to participate. We're not seeing patients physically, we're just collecting clinical data right now. So in some ways, it was a bit disappointing, but it also shows us that research needs to happen closer to home, right? And parents, being parents, they will do anything for their child. Okay. This is probably the most extreme quote that I wanted to show. Parents are willing to move to another country to get help, to enroll in a clinical trial, even if they don't speak the language. That's how the extent that parents will go to try and get treatment. So really it tells us that when the need is so great, parents will do anything, caregivers will do anything to try and even have a chance at getting some treatment that may help. Okay. And my take home from this paper really was we need to work with caregivers and parents because they are the biggest advocates for patients. Okay. So the first company I want to talk about, rather individuals from Fast Therapeutics. So this is a foundation for Angelman syndrome therapeutics. This is a rare genetic condition. It is also a leading patient advocacy group for all patients with Angelman syndrome, and they're working towards a cure, not just a treatment, a cure. Okay. They are the largest non-governmental funder of Angelman syndrome research in the world. Okay. What is their goal? Their goal is to drive forward transformative research and development as quickly as possible for those living with Angelman syndrome. They want to be at the table to set the agenda for what the research looks like, what the drug development looks like. And they want to activate and educate people worldwide, the community, about Angelman syndrome. Now, I highlighted a very important point here. This organization is driven by an all-volunteer board of parents who have children with Angelman syndrome. Okay. Now, this is taken off their website, and you can look them up as well. This is a standard drug development process. So if you look at the first part, which is the green part, the discovery and development and preclinical, the cost of developing something like that is about $2 million, takes about 3 to 10 years. To move that into a phase 1 or phase 2 trials takes another additional $70 million and probably 8 years in between. From a phase 2 to a phase 3, you're talking about 200 million. But what you see very quickly is you start off with 15,000 possible drugs. At the end of 2 decades, you end up with one, just one. So this just highlights how inefficient drug development is and how costly it is in the current framework that we have. So what did FAST try to do? The parents on the board say, we will set the agenda as what are the pillars in terms of drug development that we can try, a multi-pronged approach. So the pillar 1 is, well, we can replace mom's defective gene or turn on dad's gene, or pillar 3 is downstream targets, and pillar 4 is accelerating and preparing for clinical trials. And they have chosen to do all 4 pillars in parallel and not sequential. Okay? So all 4 of this is all being funded at the same time. Okay. So this was presented recently in the ACMG meeting. I just have a snapshot of pillar 1, 2, and 3, and it gives you an update of the different companies, different academic institutions that they are funding, and the work that they are doing, whether it's in the discovery and preclinical phase, phase 1, phase 2, and phase 3. They're not quite at phase 3 yet, but what's amazing is they have done this in a very, very short time. Okay? Now, I want to introduce you to this very inspiring person. We heard her talk at this meeting in ACMG, Dr. Alison Barron. So that's her short bio. So she's actually an veterinary internal specialist. She works with animals, not humans. But click on the next button. What happened in 2014, her daughter was diagnosed with Angelman syndrome. Okay? So when you have an affected family member, your life changes as you know it, your priorities change. What did she choose to do? She joined the board of directors for FAST. She didn't sit around and say, let's wait for something to happen. I have skills. She joined the board, and within 3 years, can you click the next button? Within 3 years, that was all the progress that you saw, right? The drug development from a preclinical stage all the way to close to phase 2, phase 3 trials now. So this is one parent that has chosen to be proactive, not sitting on the sideline, not waiting for something to happen, but to be an agent of change. And I think that's really wonderful. We need a lot more parents like this, because a lot of times we don't think we can do it. And I will tell you what my take-home message is from looking at these two very inspiring individuals. The next person is from Team Telomere, which is a disease that's close to my heart, because this is what I do in my research. And their mission is really to empower individuals impacted by telomere biology disorders through all these different methods. And their vision is really to see a world where every person impacted with TBD is including their caregivers, researchers, and clinicians have accessible care. And obviously, the ultimate goal is one day a cure. So I want to introduce you to Katie Stevens, who is the Executive Director of Team Telomere. So again, she became involved in Team Telomere after she had an affected child, right? That's the usual story, is you have an affected child, you go seek out a patient advocacy group, you be part of that team. Well, she didn't choose to just be a member. She ended up becoming the executive director that's driving a lot of this work that's happening. But I really like this quote that she has on their website is, you can't do anything about the length of your life. And that's kind of like a play on words, because in telomere biology disorder, they have shortened telomeres. So they have an increased risk of malignancies and blood disorders as well because of that. But you can do something about its width and that's what she chose to do, okay? So what does this mean for us maybe sitting here, parents of some patients with rare disease, or maybe you are a patient of a rare disease yourself, is persistence, patience, and perseverance. Okay, read all you can about the disorder, keep all your questions in the notebook and bring it to your visits with your physicians, your medical providers. Find your tribe, find your community. This is what the two individuals did, is they went to an organization, a patient advocacy group that had other affected individuals, right? But they were also very proactive in being part of the research. They were also very proactive in connecting with clinicians and scientists. And this is where it's important, because I think perspective from patients about what's important in research is very, very needed, because researchers who don't see patients and work with, say, mice models, animal models, or cell cultures, they don't understand what are the needs, right? And that's where patient advocates, parents, caregivers bring that need to the research table and say, this is what we need, this is what we deal with, this is what treatments we need to deal with the different symptoms. And advocate, advocate, advocate. Now, I think one of the things I put in there is lean into your strength as a patient advocate. A lot of times we think we don't have the training, like Dr. Allison, we don't have the skills. But I really like the talk from our keynote speaker today is all of us are enough. We have our own skills, right? Lean into your strengths and start building the infrastructure. If it does not exist, then you become an agent of change to build and start putting those pieces in place. Because until and unless we start the ball rolling, it will never happen, right? It will take 20 years to have one drug treatment, okay? So just in summary, rare diseases are more common than we think they are. Obtaining a diagnosis is important, but it's really just the start of a therapeutic odyssey. Parents and caregivers play a very important role in advocating for their loved ones with a rare disease. Clinicians and researchers depend on your stories, on your questions, on your inputs to help us drive what I feel is relevant research towards a patient-focused outcome. last but not least, be proactive and never give up. And that's both true for parents, patient advocates, but it's also true for clinicians and researchers as well. That's all. Thank you.